So, ladies and gentlemen, I'm as I said, I'm chair of infectious disease here in Southampton, and I'm actually a relative newcomer. And when I came to Southampton, and over the last couple of years, as I've looked around from the Faculty of Medicine, from within the hospital environment where I practice as a physician, this is actually what I see as I look around Southampton. And actually it's pretty impressive. Much of this research is directly relevant to antimicrobial resistance and ways of solving that. And in each of those boxes is actually an activity which, in my opinion, would be internationally rated at least 3-star in a REF panel. And includes various elements. In the top left-hand corner are more species, microbial-oriented topics. On the right are process-oriented topics. In the bottom left there you can see we've heard already about the fantastic advances made in general practice use of antibiotics in Southampton. And also some of our basic science approaches to tackling infectious disease and antimicrobial resistance. Now, shown in brown are those elements in Southampton which, in my opinion, involve direct multidisciplinary activities. In other words, people within the physical sciences, other disciplines, and medicine combining together to actually publish work currently or to collaborate going forward with Research Council or Wellcome Trust or NIHR applications. So you can see, without going into details, that there really is quite a wide panoply of research available. Now, as Tim said, we're all trained academics here, and the point about academics is that we have built into us the drive to focus down on very tiny detail and to get it right. And that's why we're academics. And of course, that tends to make us work in little silos, which is the point that Tim was making. It's hard. We're never really trained as students, as PhD students, as MD students, to think more widely and see how our work interacts with the world around us. And I think that's one of the problems. We need to start training people at a young age to think widely, to focus not just on the detail, but also how this relates to the world around. And I'm glad to see that the research councils are encouraging multidisciplinary PhD studentships. Well, back to Southampton, and my job really is to actually represent the Faculty of Medicine. So as I sit in the Faculty of Medicine, what am I seeing? I'm seeing that Southampton has, in the hospital, fabulous facilities for translational research. And Saul Forst is here, and he's going to talk about this a little bit later. Just to point out that the National Institute for Health Research has funded 2 major drives to encourage translational research. And what that means is that you can take the basic ideas from within the University of Southampton and beyond in science related to prevention and treatment of infectious disease or rapid diagnostics, and you can apply it to patients. And that's what the job of these NIHR translational facilities is to do. And we've got 2 NIHR biomedical research units or centres, one on respiratory medicine and one on nutrition, but they are both active in some way in antimicrobial resistance. We also have a clinical research facility. That's a treasured resource in a major university. That's somewhere where there is dedicated translational research on patients or volunteers with all the facilities you need to do that safely in a single environment that has all of the regulatory qualities that you need in a clinical research facility. And also we have other elements such as the clinical trials unit and the MRC Life Course epidemiology. So these facilities, the reason for showing this is basically to point out to the rest of Southampton what fabulous facilities there are within the hospital environment for networked, multidisciplinary research. On my previous slide, I hope convinced you that that is ongoing and can be done. Thank you.
Emma.
Hi, I'm going to sit down for this. So let's leave the hospital environment and go to the farm. That's where I've been doing some research, working with veterinary scientists, animal behaviourists from the Universities of Bristol and the University of Nottingham, to try and understand more about what the challenges are that farmers are facing when we ask them, can you please change your practices and reduce the amounts of antibiotics you're using on farm, which we know is kind of a big issue. So the particular problem that we were looking at was the issue of cattle lameness. Some estimates predict that almost 50% of the UK dairy herd is lame at any one time. There are various severities of this, but quick treatment can lead to not getting into the situation where you need to kind of prescribe antibiotics. So we were kind of wondering, why is it then that it appears that despite the veterinary science and the animal behaviour science having clear guidelines now about what farmers should be doing, the incidence of lameness isn't changing. So for some reason the messages are just not getting across. So my role as a qualitative social scientist was to bring new methodologies to bear into the situation on the farm, to try and think about how we can study farmers. And so what we did was we actually interviewed farmers while they were in the process of either trimming a cow foot, which is a preventative method, or more serious kind of approaches to kind of treat a lame cow by kind of actually fitting a foot block, for example. And that research kind of gave us a wealth of information about the kinds of language that farmers use when they're talking about lameness, which can, for example, you find actually that the way in which the animal scientists talk about lameness is very different from the ways in which the farmers themselves are kind of actually judging the severity of lameness. In those discussions with farmers, they never used the notion at all that the animal was actually suffering or in pain, despite the fact that there's a lot of information about how painful this condition is. We also found out that sometimes they're very much limited by the infrastructure on the farm itself to actually get into a situation where you can easily actually treat a cow, to separate a cow off and put it into the crush. There are also staffing problems. I mean, we know that actually in the milk industry, the price of milk is much cheaper than water, so there's a real lack of investment into the dairy industry to get the farmers into a situation that their staffing levels are to a level where they can even spend that extra bit of time to treat the cows. So we find a whole range of kind of social and economic factors that have a big impact on how to treat cow lameness. But we must address this form of kind of infection prevention if we're going to think about reducing antibiotics. A second project I want to talk about is a recent project which we've just put into the NERC, which is actually a different kind of space altogether. I want to take you to your bathrooms. And here we're interested in thinking about the use of antimicrobials in cleansing your body, and also how that process of cleansing your body, for example fecal matter, also carries antimicrobial load if you've been overdosed with antibiotics, and what the consequences of this material leaving your homes in the wastewater system going out into the environment. And how can we think creatively about new ways to engage with the general public, to people like yourselves, who through your everyday practice of washing your hands, cleaning your toilets, using your toilets, taking medication, disposing medication that isn't used, are actually contributing to this problem of antimicrobial resistance being passed out into the environment. And so the way we're proposing to tackle this, and this is a research proposal that has just gone in, is hopefully a proposal that will go to the HRC, because we want to use performance art as a way to think creatively about what we do with our bodies. Performance artists are incredibly skilled at understanding that relationship between bodies and practice. And we need to think about what is happening inside our bodies and the relationship that has with what we do with our bodies and with that wider environment outside, with the bodies of water, with lakes, with rivers, and with the ocean. So it's about making creative connections between the different spaces in our world. Thank you. I've got a couple of slides, so I'll see if I can get them going.
The forces.
Well, I'm going to take a little bit of a different tack. So I'm going to focus on the research that we do in health sciences. And health sciences focuses on research and education related to nurses, physiotherapists, occupational therapists, podiatrists, and also to a certain extent to dietitians, pharmacists and health scientists. So we cover a great deal of disciplines, many of which of course have much to do with infection prevention and also the antimicrobial resistance. And what I really wanted to show you today was really how we work collaboratively across the faculty itself and also beyond the faculty. And I think collaboration is really what we're pretty good at. We're pretty big on it, partly because we're so interdisciplinary ourselves, but also particularly within research, amongst our research groups. In our staff we have social scientists, psychologists, engineers, basic scientists. So we already cover a great deal of other disciplines and groups. So we already do these things, and therefore I think we're pretty well placed and have generally leapt on most opportunities to collaborate with others. And just in terms of the NAMRIT focus, I thought it would be useful to look at our research structure as it is at the moment across the faculty to see which areas do relate specifically in this field. And we have 4 research groups as shown here, and we have one called Fundamental Care and Safety, and infection prevention, which is led by Dr. Jackie Prieto, is a major theme within the research programs that we have. And I'm going to come to contents later as a little bit of a focus, but just to say that we already, with the NAMRIT work, have developed collaborations on skin health with engineering, where we're looking at methods of cleaning wounds and reducing infection loading within wounds, and also on skin health, on cleansing, cleaning with wipes, for example, in hospital. And then that's led by David Vigelli. And then we have a group focusing on medicines optimization, led by Sue Latta. And this group is really has been very much focused on non-medical prescribing. So we've had a lot to do with medicine in terms of our collaborations there. And as part of the NAMRIT work, we have some work going on looking at different ways of safely prescribing antibiotics so that they can be used. And that's led by a pharmacist within that group who's got a poster here today, Kieran Hand. And then we have quite a large programme of work in the continence, bladder and bowel management group, which is my own. And I think I'll just give you as an example of how we've used different forms of disciplines and collaborations to help with this work, some of which has been taken up within the NAMRIT focus. And we've got some presentations this afternoon on this, so I won't go into any great detail here, but at the sort of higher level our mission really is to understand the use of urinary catheters, and you can see one here. Urinary catheters are a leading cause of healthcare infections. They're a tube that goes in the bladder and are held in the bladder by a balloon, and we'll talk more about that later. And what we need to do, if we're going to reduce infections that are related to catheters, is we really need to understand catheter use. So we understand why do people use catheters in the first place. And this requires us to collaborate and find out what happens with medicine and nursing in particular. And one of the interesting things we're finding out there is that anaesthetists, for example, are responsible for a lot of decisions that are made about who gets a catheter, mainly because they're interested in things like fluid monitoring, but also because they provide anaesthesia that paralyses the bladder. So there's a lot of ways we need to understand if we're going to stop the use of catheters and reduce their use, who actually makes all those decisions and why do they make them? And one of our presentations this afternoon will go into that. And then we're also looking at developing alternatives. If we're going to reduce catheterisation, we need to look at alternatives. So what can we do to as a way that will do what a catheter does? One of the reasons to have a catheter is to drain the bladder because of urinary retention. So we need to know how much urine is in the bladder, and also for fluid monitoring purposes. So there may be
really good opportunities here for looking at different methods of actually measuring the volume of urine that is in the bladder in another way. That would be a very important way of avoiding a lot of catheter use, which could be exploited. Another reason for using a catheter is urinary incontinence. People are given them because they have problems with toileting. If there are better alternatives to toileting, if people can be helped to toilet in different ways, there will be less use of catheters. And this requires us to work with engineering in terms of thinking about how do we design, for example, different kinds of female urinals. And then there's the focus of designing better catheters. Now, catheters are made, the actual design of a catheter is 80 years old. There are no new catheter designs since that time. They're not made of state-of-the-art materials, they're made of very standard materials. So understanding how could we design better catheters, both with the different materials that resist biofilm formation, how do we understand the formation of that biofilm in the first place? So many collaborations as we have with biological sciences, and also with material scientists to learn what kind of materials are going to resist those forms of colonisation. And then finally, of course, we need to know the design of the catheter itself. The physical design is not the best design, and I'll talk a bit more about that later. And therefore, how can we work with other engineers to make a better design that will work better for the bladder? So these are just sort of examples about how I think we already are collaborating way across the university to really just focus on one key area, which relates to the health infection prevention of infection agenda. Thank you.
Any idea how I can edit this one? Skip, oops, I don't know. While Tim helps me out here, as Tim has said, the idea of technology, so I come from the Faculty of Physical Science and Engineering, technology or science. So the idea of, I'm Rob Easton from FBSE, Associate Dean. The idea of having any kind of technology or science is no good unless you can get it out there. So we are trained as scientists and technologists to do things in our labs. Great, good for papers, etc. No good if the general public or the cause is not served. So I've got just 12 points here. It's a bit like a SWOT analysis, the strengths, weaknesses, opportunities, threats. There's no priority in these 12 points, but here they go. So one thing is working together in bridging this gap between the EPSRC, Engineering Sciences, and the medical world, MRC and BBSRC. And that's tricky. From my own point of view, trying to get funding in these areas can be tough. So the interaction between colleagues, there are about 5 or 6 colleagues in this room who I and my colleagues at the back are working with, and that's very important. Trying to get that interaction is so valuable when I don't speak their language and they may not speak mine. But you know, people like Mandy and others in the room, those key places, IFLS, medicine, health sciences and more, that's vital to get any kind of dialogue going. And assessing viable engineering solutions to AMR problems. So everybody's got a solution to something in their heads. Unless it's cheap, easy, and can be used routinely, you know, beware of having great ideas unless you can get them out there. And what we've been doing recently is working with COIs in these other schools and disciplines to get funding to address this kind of bigger problem. So some challenges here. Devising and applying solutions that are cost effective. It's no good making £1 million machine if you only make one of them in your lab. You know, any applications for AMR or others must be out there and must cost just so little so that the world can use it. That's a message I've learned to my cost recently. Understanding the medical or clinical need and persuading some to adopt different practices. So I'm talking to some medics recently. You know, the phrase that we can't possibly do this for takes 5 minutes. Understanding their problems. And if my engineering approach takes 17 days to do something, that's just not going to work. So knowing what they need. The language also. When I was much younger, at age 13, I chose my O-levels, remember those? And the choices between biology, woodwork, Latin, or Spanish. And I chose Latin. So no biology at all, but now I need it at age 60 plus. And so working with those colleagues who know the language between medicine and technology can be very hard to broach. That just doesn't help. So engaging with medics who have the time to work up an idea, and there are a few of them really, So engaging with a few folk in the audience here who have that time and can explain to me in very short sentences what they need, and we can then offer our technology or our science solutions to make that work. And getting that right, if you can hook up with medics and cross-disciplines, invaluable. And maybe there could be some solutions then to AMR. As Tim said, and I'll say again, we do work in the lab, and our boring old engineering practices may be something very new to the world of medicine. And although you mustn't just focus on that and say, we're going to solve our problems unless you really can. So keep it simple and easy, and I'm encouraging my colleagues in FPSE to think of easy solutions. Don't make things that cost just too much and you make one of them. That's never going to work. So draw on current FPSE technologies, and it doesn't matter what it is. Electronics, photonics here, lightsaber, ultrasonics, imaging, doesn't matter, provided they will end up in a new application which will solve or help contribute towards, say, the AMR problem or beyond. So although you have your pet subject here, don't flog it unless it's really going to be a benefit. And unless you can demonstrate a real and quantitative benefit, then I would say keep your idea in the lab. But if you think it can work for applications in medicine, etc., then go forward. So in practice, what we do in FPSE, a few things, we talk to people, have regular meetings to exchange ideas, and that needs people to be contributing to it. I encourage people to do that. Cross-faculty events, that is very easy to organise, hard to make work, and give an outcome. And then finally, applying to all RC UK and beyond to try and get funding, which in my case is mainly EPSRC, but also then MRC or BBSRC, to get that nugget of an idea and to get it funded, and to have on board a range of academics involved in that project. So that's what we do in FPSE. It's a big ask really, because many people, A, haven't got the time, don't know about it. Getting that dialogue going, I think, is vital. Okay.
So I don't have any slides, and unfortunately, I don't have any success stories. As it works, I was drafted at the last minute for the faculty lead for business and law and art. Never met her, and never received an email from her. So in terms of just the basic interworkings, we have a lot to learn, obviously, from other departments. We used to be the faculty of business and law until a few months ago, until we recruited or were asked to take on the Winchester School of Art. So there hasn't been much collaboration as a new institution added to our faculty. But our main problem is that there's a lot of talk and encouragement for interdisciplinary work, but there's little encouragement and reward for that work to be undertaken. And as a result, within our faculty, there is little in way of new methods and new knowledge being undertaken in relation to antimicrobial resistance. I think part of the way, at least in relation to our faculty, people have an understanding about ethics being, that's all subjective and opinion, and it's all a bit of navel-gazing, so why take it seriously? Or in terms of law, people think of hard law measures, maybe statutes and cases, but they neglect to think about other soft law measures in terms of regulations and governance and other kinds of professional guidelines that actually are the concern of legal scholars and practitioners. So I think part of our work is not only in terms of working better with each other, but then being able to communicate to other faculties what kind of contribution, attention to considerations of ethics and law might add to these kinds of collaborations. Where I've had some success is in terms of not trying to cram together different kinds of disciplines, but in terms of the way in which different disciplines have acted as a conglomerate to tackle a particular social issue. So in relation to responding to disasters and emergencies, and in particular, trying to look at some of the ethical and legal issues related to disasters and emergencies, focusing not on particular disciplinary issues, but on trying to implement those different kinds of responses and resources. And so in work with the CDC and the WHO, I've had independent success in terms of incorporating ethical and legal considerations. I was able to join Emma on her project in relation to wastewater management. But it's all been individual contribution. And so our faculty needs to obviously work a lot better in being able to contribute to the interdisciplinary activities of the group. Thank you.
Great, thank you everyone. There's quite a range of statements there. Does anyone have any initial thoughts or comeback or questions? Noting that this is a new network. We're going to be doing things wrong. Maybe there are academics out there who feel we haven't met their needs. I mean, please tell us about that, because we have small amounts of money to give you in pump priming, and we have cake. And, and those are our two super weapons. And if you can think of a novel way of using them, or of some other resource you'd like us to deploy for your benefit, then please let us know. Has there anyone got some things that they want to share? Yes?
I just wondered what role or how much economists have been involved in the network, because quite often in terms of impacting on policy or attracting kind of investment, there's nothing quite like an economic evaluation or quality of life sort of measures, etc. And I know there are health economists in Southampton, so I just wondered how much the economists have engaged in the network and what opportunities there might be.
Thanks. We haven't had a huge amount. Is this working? Sorry? We haven't had a huge amount of involvement. I did put out to people at the pump priming when we did the first launch that if you can state that a problem is worth so much of GDP or so many millions a year, you're far more likely to be able to get traction at the higher political levels. And so we would be very welcoming of a pump priming multidisciplinary study that looked for that kind of thing. But none have been put forward. I think we've had 11 or 12 put forward so far of these pump priming studies, but none of them were for that. But yes, please.
Although, as you rightly say, we do have some sophisticated health economic expertise in Southampton. The case is that when you make applications to NIHR, National Institute of Health Research, for particularly late phase research, we do always try to involve our health economics expertise from After Yao in our applications, because we find increasingly that's an essential component of any grant application we make. So although they're not actually represented here, the reality is that certainly when we're making applications from the Faculty of Medicine or from Health Sciences, we will involve the health economics teams.
But I think that yes, but the case is I would like to be able to drag out of, I'd like to have a portfolio of things that we could find, and you can't find them in Southampton, you can't find them on the web, you can't find them in literature, that just say the cost of not washing your hands, flushing the toilet, putting throwaway packaging in one place and not another. It would be very useful to have these, because eventually, as you try and look at steering policy, you meet somebody who needs a pound sign or a number of lives.
If I can comment briefly, in EPSRC, certainly the impact agenda is very strong, and so we have to do a 2-page impact statement, which initially we hated, thought it was useless. Now it's very good. It's actually a very good study to do. And so economics and social consequences and health, etc., are all easy targets to be able to write about. So any kind of the grant we've just recently won for nice amount of money from EPSRC, it was easy to write 3 nice paragraphs highlighting the value to society and to the economy and to the Bank of England, and it was great. So yes, that's very important from that point of view. Yeah.
I agree, but the quality matters, because I've seen such statements that say, I work in tarmac is worth so many billions to the world, my research is worth so many billions. And what you actually need is, if I had not been born, so many thousands would have been lost. I think it has to be good quality, and I think that There are lots of numbers out there that I'm not saying yours are great, I read yours. But you go on the web and you find poor quality quantification. And we know already, you know, forgive me for the numbers, but maths is worth 40% of GDP, medicine's worth 60% of GDP, engineering's worth 80% of GDP, and these numbers just keep going up. We've got no wonder the Chancellor thinks we're rosy. Anyway, Bill.
Yeah, Guy's made a really important point. It's certainly in terms of the copper story. The copper industry commissioned an independent survey by University of York. They didn't involve us or anyone else because they wanted it to be an independent one. And based on the reduced morbidity and mortality, they calculated at York that the payback time for a hospital to retrofit in copper was about 2 months. So that's actually had a major impact on the deployment of copper around the world.
Great. Are there any questions, comments? Yes.
Thank you. I really appreciated the comment that Professor Reeson made about needing to, I think it was understanding language, and I just wondered whether you had any thoughts from anyone in the panel as to whether you've had any difficulties in getting past the perception of this as a primarily medical problem. Obviously you have, and that's precisely the intention, but in my university in social sciences, and I was wondering whether your experience in the business, law and arts area might relate to this. You have sometimes had to work quite hard to explain why this is an issue that goes well beyond it being a problem which is best addressed by the health sciences, or more specifically by medics, because it's seen as a very clinical issue.
Okay, so as a comment, yes.
Well, it was a question, an invitation for the panel to say something about the extent to which how you go about fostering multidisciplinary approaches, and how you get beyond the siloing, which is largely relating to jargon, to explain why AMR, which sounds like a very technical term, is in fact not just about microbial evolution.
Maybe if I comment first, yes. I mean, my jibe about never having done biology sadly is true, and which is why I try to pretend I can do it. So within this room, I don't know very much about biology at all, but working with colleagues, and that's the hard bit. Getting people in the audience who know I am working with, getting those on board so you have this team is invaluable. Without it, you're really sunk. And trying to get them to commit their time and to explain to you in boring detail about what a lipid is or what a something is, which I've never heard of before. It's that level of detail. Equally, from my point of view, talking about higher photonic structures, and they just turn off. So really, you need to go back almost to O-level, in my view, or GCSE now, which is, and to just explain in really terribly easy detail why you can do this, and how much it costs, and how big it is, and does it degrade, and to talk to the medics and the biologists and all those people who know what they want, but maybe don't know the technology you have available. It's getting that marriage between a range of people. If you get it, hold on to it. It's really tough.
I just want to expand a little bit about I'm a big fan of the plain English summary, and I often think that perhaps engineering and other areas could do more plain English summaries. We have to do them in healthcare a lot, and even we're not necessarily that good at it, but sometimes, particularly when we deal with other faculties, they've probably got something that would be useful, but we don't really understand it enough to know how it could be useful. So, even when we run a conference to do with engineering, and we ask people to talk about it in plain English, because it's a mixed group, and actually they often can't, I presume. So probably we need to do some help with this. Maybe this is a good point. Now it's funding, my plain English.
We ran a training day. If you look at what we did, is we got people in the room, volunteers, and we asked them to tell them about their work, and it was ghastly. A lot of people would have 6 Latin words strung together as their first opening introduction, which would be fine for Rob, but not. By the end of the day, we asked everybody to describe their research to the general audience in 30 seconds. And it worked very well, and we filmed some of those on the TV screen in the lobby if you have a look. So it's just one day of working at it, and it makes a big difference. So we have done that once. We can certainly do it again. I think it's hugely important because we're all of us swimming against the tide in this. If we don't make an effort to communicate and find collaborators, they won't happen. If we just do a bit of research, we publish it, and we're complacent, hoping somebody else will pick it up and roll it out to the public in its thousands, they won't. And if we research councils and we don't keep pushing and pushing the ability for people to work across disciplines, it'll just start sliding back. I think that's a crucial thing. We are swimming against the tide. Richard, you have a question at the back.
Thanks, Tim. Richard, FO Medicine. Thanks to the panel. Just one thought. One thing that used to work quite well in medicine was forced collaborations, and there's nothing that attracts academics more than a small amount of money. You don't need very much money to attract academics. So, in terms of, is there room for having geography, health sciences, and engineering with medicine in 5K pilot projects that insist that at least 2 faculties or 3 faculties take this forward? Or is this already running tonight? I'm not aware of that.
It's running.
It is running.
It is.
And
Yes.
what's the take of being across the faculties?
We do have that graph. I can put it up on the screen at the end of this.
Okay.
I cut it out of my opening talk. But what we've done is we've got a pump priming scheme. We've given out 150,000 so far in sort of 10 to 20,000 pound packages, which buys about 3 months of a postdoc time.
Sure.
We've had 2 rounds of funding, and there are a number of things criteria that people have to satisfy. It has to be EPS and non-EPS collaborators, because that's what EPSRC, who gave us the money, gave us it for. So that forces a strong representation from engineering, maths, physics, physical chemistry. So it has to be that. It has to be new, it has to be novel, it has to be focused on AMR, it has to really, in simple words, have an AMR outcome. We had 2 calls, and interestingly, we had all the bids peer reviewed. We sent them back to say, look, we need these changes, these changes, these changes. Now, you're used to having peer reviewers tell you a bid needs rewriting and rechanging, and then sending it back and having your heart broken. But interestingly, we've now got a 100% hit rate, because every bid that came in was pretty good to begin with, but it needed more. And everybody who we peer reviewed and told them it's not right, altered the bid to make it work. And it's funny that we're having such good bid altering for 10 to 20,000 pounds when it's quite hard to get somebody to really address reviewer comments on a £1 million bid.
It is, and I think it might be worth also letting people know that there are very few chances where you have a 100% success rate.
Yes.
That's certainly something that
I don't know.
maybe should champion.
I don't know. We have put it on, and we certainly, yeah, we have mentioned it. We do intend to publicise it a lot more, because we can't keep it up. Because the moment you say you've got a 100% hit rate, everybody, and I hope we get 100%, because to be honest, the failed bids should be going to Research Council to get 20,000. I don't know, you guys don't give out 20,000, do you? Not really. I'll be so lovely. Give me $1 million, and I will give it out in 20,000 chunks for the best set of budgets you've ever seen. Thank you, Richard.